Hi friends, let's learn the facts and the practical issues of an important ICU procedure called ICD or intercostal tube or chest tube or thoracostomy tube placement. What is this tube like? Why do we need to place it? This information will be useful for everyone who is watching this video. Chest tube is a flexible tube that is inserted through the chest wall between the two adjacent ribs into the pleural space, also called the pleural cavity. The cavity that exists between the lungs and the underneath chest wall. It is normally empty. Now let's know something about this tube. The material of this tube is usually polyvinyl chloride or PVC, polyethylene or silicone. The PVC is commonly used because it is cheaper. Silicone is softer, associated with lesser pain and drain side infection, but costly material to make such tubes. Different sizes of the tube is available from 6 French to 40 French. Smaller tubes are meant to treat pneumothorax and less thick pleural effusion. Larger tubes are ideal for drainage of hemothorax or empyema. 28 French or larger are needed for the drainage of blood or pus in the adults. The tube has few fenestrations or holes along the sides of the insertion end, which ease the rapid drainage and increases the dwell time. The tubes have a radio-opaque stripe which helps in the identification of tube on chest X-ray. Now we should know about the common indications of chest tube insertion. Urgent indications are tension pneumothorax or a massive pleural effusion which compresses the heart and also the other lung, resulting in severe hypoxemia, desaturation and respiratory distress. Such situations require immediate placement of chest tube by an expert in emergency department. The other indications of chest tube insertion are hemothorax and empyema-thoracis. If we talk about the contraindications of chest tube placement, there is hardly any, okay? And mostly the contraindications are relative, such as the pulmonary adhesions from previous surgery, pulmonary disease and or trauma. Coagulopathy and diaphragmatic hernias can be a contraindication as well. I'm sure that by now everyone will be more interested in knowing how we can insert the chest tube, the technique. So guys, it is an interesting part of this video and very technical, so pay attention. Before even starting the procedure, you have to make certain preparations, right? Like positioning of the patient, identification of point of insertion of needle puncture or incision on the chest wall, and consent part from the patient after looking at platelet count and INR, etc. For positioning of patient, ideally head end of the bed should be up about 45 degrees and hand of the ipsilateral side of the patient should be behind the head, and this positioning is most visible for a patient who is critically ill or in ICU. Sometimes patient may be on mechanical ventilation and therefore it is necessary to keep the tidal volume or respiratory pressure to the lower level and PEEP also to the minimal level or about 4 to 5 centimeter of water, just to avoid the possibility of pneumothorax, right? So now a thoracostomy tube is usually placed between the mid to anterior axillary line in the 4th or 5th intercostal space. You need to be aware of the fact that where to track the needle above or below the rib. So remember, you need to track the needle above the ribs, so you need not to injure the intercostal bundle. So there are 3 main approaches for accessing the pleural space: surgical technique that involves incision and dissection, trocar based technique, and Seldinger guide wire based technique. Each one of the approaches has its own advantages and disadvantages and depends on the patient's and the doctor who is performing the procedure. Most often, the surgeons are comfortable with surgical incision technique, whereas other 2 techniques are commonly favored by the intensive care physicians. So as you know that I am an intensivist and we prefer trocar based technique or Seldinger wire technique in our ICU. Now a few words about the role of ultrasound while placing ICD. Ultrasound guidance improves the success rate and safety of the procedure, especially in ICU where optimal position for ICD is difficult to obtain. Complications may arise in up to 25% of the cases in a blind technique in ICU. These vary from drain misplacement to the lethal iatrogenic injuries. Ultrasound decreases the rates of complication due to needle puncture. So now my dear friends, allow me here to show you a video of a trocar based technique of small bore ICD insertion. So after you have placed an ICD successfully, you need to secure it, right? Two types of sutures are generally placed. One, the suture of chest tube is placed with a large silk suture, number 1 or number 0. Go around the chest tube several times, clinch down to create a small waist on the chest tube, and this is called the stay suture. The second suture, which is called the close suture, should be used to close the incision. Okay, and this is a mattress kind of suturing to avoid the leakage or introduction of air. Now, what do we do with the proximal end of the tube? The proximal end is usually connected to the water seal chamber or ICD bag. Water seal acts as a one-way valve allowing air to escape from cavity but not to re-enter to the thoracic cavity. A minimum of 2 cm of water seal is required in the chamber, as is shown in this figure. Now people often ask, when is the appropriate time to remove the chest tube? The simple answer is that the indication to place the tube is resolved, or if the tube is causing complications. Look in chest x-ray if lung is expanded well and less than 200 ml is drain output in last 24 hours, then you can safely remove the tube. Always take precautions to seal the hole at the skin while taking the tube out. There are few additional tips to remember while you are removing the tube. 1. Avoid discontinuing the tube upon inspiration, because this develops a pressure gradient inside the chest and that have air tract intrathoracic, causing a persistent or recurrent pneumothorax after discontinuation. 2nd, ask the patient to hold a breath. 3rd, an occlusive dressing with Vaseline or zero foam gauze is preferred. 4th, placing a U-stitch around the incision site and tightening when the tube is discontinued is another option to seal the thoracostoma. It is needless to say that follow-up chest x-ray is needed. So that's all for today, and thanks for your attention. Please subscribe and like this channel. Thank you so much.